Greetings, everyone. Yes, here I am. Oops, sorry. Here I am. And I bring my chief should have been here, but he had quite a problem, so I'm here with my presentation, talking to you about carbon fiber implants in orthopedic oncology, so not in spinal. Someone else will speak about spinal surgery here today. I come from Turin, in this university hospital, and in our experience with in orthopedic unit, which is primarily dedicated to bone and soft tissue tumors. We are an orthopedic oncology specialized unit. Before we use implants, and the implants we know of are of metal. The carbon fibers are something new, and so we have plates and nails and spinal systems and prosthesis. All of this come in our job for treating the patients with tumors, metastatic or primary. And when you talk about carbon fiber implants, we still do not have the prosthesis, but we work with plates and nails and, at last, even spinal systems. We do work with spinal systems here. This is a job of mine, but someone else will talk in the next instrumentation, in the next presentation. Although sometimes the spinal and not spinal orthopedic oncology can cross the border with each other. For instance, this is a lumbo-pelvic stabilization after a hemisacrectomy for a chordoma, chondrosarcoma of the iliac wing. In that case, the spinal instrumentations go in the pelvis. And the carbon fiber implants are, of course, are a new material that you use to treat the same diseases using the same hardware design. And when I thought about this, the question that I did to myself was, are we just doing something fancy? We have a new material and we use it because we like new things, but is this carbon fiber really something new, or is it just something nice to see at the X-rays? And the difference, the answer to these questions is different. Although, if we are talking about metastatic tumors, primary tumors, or in spinal oncology. And the spinal oncology, it's already known as the carbon fiber, a paramount game changer in the treatment. But in metastatic tumors, in primary tumors, we can talk about this. Because in metastatic tumors, what we do with our implants, we treat or prevent pathological fractures, or sometimes we use a plate to reinforce an osteolytic defect filled with cement. And as you can see, a metal implant with a metal nail is not so different in reality with the carbon fiber with the metal nail. They are almost the same nail. They are different on X-rays. In upper extremity or in lower extremity. You can use metal, you can use carbon fiber, and there are reasons to use both. But why we prefer carbon fibers? There is a radiolucency, we already talked about it, which is good for radiotherapy, and already talked about this, but it's really good for follow-up. And this is a plate, and there are absolutely no artifacts. You can perfectly see what is beyond the plate, under the plate, between the plate and the bone, with a carbon fiber plate, and with a very nice imaging. But not only for the radiolucency. Even if the carbon fibers were radio-opaque, if they had these mechanical properties, which we already heard before, that already would be a very good reason of using them, even in metastatic tumors. Mostly because we had our fatigue breakage of metal implants, and we are confident that the fatigue resistance of the carbon fiber would avoid probably these kind of problems. And the other thing is that when you have a diseased bone, having something with a modulus or elasticity less stiff, with a better modulus of elasticity, would prevent the breakage on the sides of the implant. And that is the reason, mostly because we like this kind of implant in metastatic tumors. We have our experience in the last 4 years. We did our job. We did use many carbon fiber implants in metastatic, in primary tumors, and in hematopoietic tumors. So it's a couple of examples for our casuistics. And upper extremity, this was a myeloma. And sometimes we do not lock the nail, sometimes we do, depends on how mobile it is. Or in the lower extremity, tibial, or the newest product of the line, the long femoral nail. After doing some surgery, we asked ourselves and asked our radiotherapist about some consideration about these materials, and they showed they had a better visualization of the radiotherapy planning. They had less shielding or less scattering of the radiations. So we had happier radiotherapists and happier physics, which is something very exceptional. A happy radiotherapist is something you don't see much. And nevertheless, although the patient had a better radiotherapy, for sure that they had, in the metastatic tumors, this was just a study about metastatic tumors, this did not bring a different treatment. They had a better treatment, but not really a different one. It didn't change the game. We asked ourselves why. And the reason is that we chose the wrong cohort of patients. Because there are no radiosensitive organs nor vital in the limbs, and the metastases have standardized treatments. There is less drive to do the spatial treatment just for that patient in a metastatic patient. And so the radiotherapists did not change their radiotherapy for the metastatic patient, but the metastatic patient had a better radiotherapy altogether. Because if it doesn't change the final treatment, why bother? We keep use the carbon fibers because there is a better visualization of fracture healing, a better postoperative imaging, and after all, we give an easier work to the radiotherapist, and this is good for them and for the patient, and mostly because the biomechanical characteristics are still valid even if the radiotherapist says, I'm going to do 20 grays to this patient, whether there is a metal implant or a carbon implant. But the biomechanical characteristic of the implant will be good for it. So, are carbon fiber a game changer in non-spinal orthopedic oncology? I would say that in the metastatic disease of the lymph, they make a better game, but they do not change it. But what I'm going to talk about is about the primary tumors. And in this case, they are different. With examples. This was a lady with a low-grade chondrosarcoma. A low-grade chondrosarcoma can be treated with a curettage and the local adjuvants and grafted. You don't need to do the resection in a low-grade chondrosarcoma. And so we did. And we did a curettage, a local adjuvant with phenol and alcohol and thermal therapy. And then we did a bone grafting and did put this distal femoral plate the first one. And we were able to see the evolution of the grafts with a very good evolution of the grafts, the healing of a tumor after 10 months. And we could have this kind of follow-up. It gave us a very nice certainty of what was happening. If we had only artifacts from metallic screws, it would be very nice to have carbon fiber screws, even the plates, Mr. Carbofix. But even this is very fine. This year we removed the plate because there was no tumor, and so it was time to remove the plate. The bone was healed, and we could see that there was no metal debris, no carbon debris. There was no phlogosis, no fibrosis. The plate was very easy to remove. You just pulled out the screws, and the plate went away. There was no necrosis under the plate, no scar tissue. It was very, very fine. Another case. This was an older lady with a leiomyosarcoma of this area of the tibia, just in front of it. And we have a very bad experience with the intercalary prosthesis. Almost everyone we put got either infected or mobilized. So we tried to do something else. And so this was a tumor mass. And we decided to remove the corticotomy. We did this corticotomy. We did a local flap of a muscle, gastrocnemius, and a skin graft. And we reinforced the tibia with a carbon fiber nail. The lady went walking, everything was fine, and we had a very nice follow-up with MRI, with CT. We could see everything. And we could see even that after 20 months, we had this bone regrowth, which was really amazing. We did not expect this. It was very fine. And the lady walked without problems, without crutches, until she had a local relapse, just under the corticotomy. So we operated her again, did another corticotomy. She is still with us, and without local relapse. We added the distal screw at the time because it was too big the gap now to just rely on the nail by itself. And she is doing radiotherapy right now. And again, this is something that we shouldn't be able to do with a metal nail. Maybe we could do this, but it would be very much more difficult to manage. Another experience we have, we work with the pediatric oncologic. And here's our case. It was a 4-year-old in 2010. She had a Ewing sarcoma of a diaphysis of a femoral shaft. So we did a massive allograft from a tibia of a donor with inside the fibula of the patient. And this is not a femoral plate, this is a shoulder plate turned upside down to rebuild the femur of his kid. And after it went fine, in the oncological point of view, she is healed from her tumor, and we saw what would happen. The graft went very well, the fibula became a femur in the time, but we had problems with the hardware. So after 3 years, we had a cutout of a plate. We had to put an 8 plate to treat a valgus deformity, which was going harder and harder, deeper and deeper. So, and after 5 years, we decided to remove a plate because it was completely cut out from the bone. And this kid was ran, went to school, had a normal life. Such a normal life that she broke and under the trochanteric region. It was a pathological factor, actually. She just did a little small jump because this was not a healthy bone. And so we put a metal implant to treat this fracture with another graft to give some more bone. And what happened? in 5-6 months, she broke under a plate. And so we reconnected with ourselves and decided to use the carbon fibers. And this was last year. Again, a carbon fiber straight plate, some more bone grafting. You never had too much bone grafting. And what we could see was a very nice healing, and mostly we was able to see the healing through the plate, or through the plate. We could see the callus starting to form very slowly. We are talking about this is not a femur, this is a fibula with the tibia of a cadaver tornator. So we don't expect a very good healing here, but it is healing. And this is on June of this year. She's walking, she's running, she's fine, and we see the healing of this fracture, and you see it through the plate. And this is amazing. We love this, of these products. And I'm going to show you the next case, which is the last. Another child. This was 5 years old, 4 years ago. He had an osteosarcoma of distal femur. He was a very thin kid. So we treated with a resurfaced allograft. So it's a prosthesis of aluminum. And this is not a femur, this is a humerus. And this, again, is not a plate of proximal, of a distal femur, is an upside-down shoulder plating. They work perfectly in the children. And he did his chemotherapy, he is survived, and this after 3 years. He had this very good fusion of his allograft. This year, he broke the allograft. It was expected. Sooner or later, it would happen. We are trying to buy sometimes to put a growing prosthesis to the skin. And now we put a femur reconstruction with a carbon fiber plate. And again, we could see a very good and very quick healing and fusion of the allograft. This is yesterday, so this is a WhatsApp photograph that I got from my colleagues, but it shows really what is happening here, not here, but here, in the fusion of the allograft. And so, coming back again, are carbon fiber a game changer in not spinal orthopedic oncology? Well, yes, they are. When you are talking about primary disease of the limbs, they are changing the rules, and we are treating some patients in a different way because we have carbon fibers. And we have new fields to play. And thank you very much.